Welcome to Pediatric Airway Disorders and Parenchymal Lung Diseases. This is based on Walsh's Chapter 23. Today you'll learn to identify and name both upper and lower airway disorders. You'll also be able to, at the end of this lecture, recognize signs of severe or complete airway obstruction. These may require interventions. You should be able to describe the basic interventions and recommended therapies for each of the airway disorders discussed, and discuss different types and therefore different etiologies of pneumonia. Let's begin. The special susceptibility of children to disorders of the airways stems from several factors. One of these are congenital anomalies of the airway structures. These tend to cause difficulties very early in a child's life. This is due to some of the normal anatomy with tiny kids. There's a small airway, and that puts children at distinct disadvantage. The trachea is narrow. The bronchi and bronchioles can become critically compromised very quickly by very little swelling. This happens in the mucosal lining as well as if they aspirate a foreign object. There is increased susceptibility to even the slightest of respiratory infections and a tendency to put everything in the mouth. That's a risky behavior for a small child. Other differences also are common. The mouth is crowded. The tongue is large in comparison to the rest of the mouth. And the nose, nasal pharynx, mouth, oropharynx, and structure of the larynx are closer together. The epiglottis is floppier and U-shaped in a child and shorter than that of an adult. The vocal cords slant upward in a child, where in an adult they're more horizontal. And the infant's larynx is higher in the neck, nearer to C3 or C4, and the cricoid is the smallest part. The trachea is less rigid in a child and very narrow. And the larynx is more to the front and higher in a child. The lungs themselves have less capacity in a child than those of an adult. An adult can take a deeper breath. As in an adult, the trachea divides into two main stem bronchi, the left and the right. These divide into smaller divisions called subsegmental bronchi. And this is repeated over and over until once they reach adulthood, there are 23 generations. However, in an infant, there are only 16 to 17 generations present, and this results in a smaller area for gas exchange. Let's start by talking about airway obstruction. Obstruction of the upper or lower airway of a child may lead to a life-threatening hypoxia, low oxygen in the tissues, or hypercarbia, too much CO2. With high risk of death comes the need to identify quickly the cause and recognize the clinical signs and symptoms and choose the diagnostic methods for treatment of many of the causes of airway obstruction. X-ray evaluation of the upper airway includes both frontal, anterior, posterior, and lateral views of the head and neck. When performed properly at the right angle and exposure, these films can be helpful in evaluating what upper airway obstruction is present. However, children may wiggle, scream, and further increase their respiratory effort, and this can make them extremely difficult to examine. A child's narrow airway makes even a small obstruction significant and can lead to a marked increase in respiratory effort. Clinical signs of impaired respiratory function, like tachypnea, nasal flaring, retraction, cyanosis, and even a change in mental status, include a reduced level of consciousness or increased agitation, can also make it difficult to examine a child, but need to be recognized quickly. As a rule, tachypnea and nasal flaring alone suggest a less severe but earlier stage of obstruction. However, if obstruction is severe with prolonged respiratory distress, the child may become exhausted and only able to exhibit nasal flaring, so be cautious. In infants, the exhaustion of respiratory muscles leads to increased dynamic compliance and ineffective respiration. They have a relatively soft rib cage, and this leads to increased chest wall compliance. The child's mental state may range from fearful and agitated to lethargic or even unconscious. A child with mild hypoxia tends to have increased levels of agitation, whereas a child with increasing hypoxemia and increasing levels of CO2 becomes more lethargic. Listening to the child's upper airway over the trachea and lower airway over the thorax is vital to determine the extent of air movement and obstruction. Some sounds, such as stridor, may be so prominent that you can hear them from outside the patient's room. Stridor is a coarse, vibrating noise generated by the airway in soft tissue that typically occurs in the presence of a narrowed or obstructed upper airway. Extrathoracic obstruction of the trachea causes stridor during inspiration. The deeply negative intrathoracic pressure causes the pressure inside the trachea to fall and allows the higher atmospheric pressure to collapse the trachea. This results in a crowing sound or stridor. During exhalation, the positive airway pressure forces the airway open and can eliminate the stridor or when the child is relaxed. If there is an intrathoracic airway obstruction, you may hear inspiratory and expiratory stridor, or stridor on just expiration. Lower pitched sounds signify mild obstruction. Higher pitched sounds signify more distress or a worse obstruction or limited airflow. Sounds heard on inspiration but not expiration may indicate a ball valve obstruction and accompany risk for pneumothorax. Absence of air movement constitutes a true emergency. Superlaryngeal obstruction. This includes deep neck vein infections, tonsillar enlargement, as pictured here, and peritonsillar abscess, also pictured here. Let's start with talking about deep neck vein infections. Deep neck vein infections are a complication of upper respiratory and upper gastrointestinal tract infections. Aerobic and anaerobic pathogens are a common cause. They can become rapidly severe, causing airway obstruction and aspiration, and quickly spread to adjoining structures. like the mediastinum. Antibiotic treatment, airway protection, like intubation, and surgical intervention may be necessary. Peritonsillar and retropharyngeal abscesses are very common examples of these infections and must be differentiated from simple tonsillar enlargement. Let's talk about simple tonsillar enlargement. A child with acute illness characterized by fever, sore throat may develop swelling of oropharyngeal tissues. Inflammation and swelling can progress to airway obstruction, tonsillitis, streptococcal or strep throat, and can produce large amounts of exudative pharyngitis. However, the presence of cough and nasal congestion increase the likelihood that the infection is viral. A throat culture is needed or rapid strep test to identify what is causing the problem. Therapy is routinely restricted to antibiotics unless the swelling is severe. Peritonsillar abscess commonly forms unilaterally around the tonsillar tissue. So it causes unilateral or on just one side swelling and protrusion of the affected tonsil into the oropharyngeal space with a deviation of the uvula to the unaffected side. Patients commonly complain about difficulty opening the mouth, a sore throat, and muffled or hoarse voice. Diagnosis is made clinically and by culture. If in doubt, frontal, anterior, posterior, and lateral radiographs of the head and neck can aid in the diagnosis. The most common cause of this is Streptococcus pyogenes, or strep A. Staphylococcus aureus is another common cause. Retropharyngeal abscess commonly occurs in children younger than 3 years of age. It displaces the posterior pharyngeal wall forward and can obstruct the airway. Infectious agents involved are group A strep, Staph aureus, and occasionally anaerobic bacteria. The child often presents with a sore throat, a fever, dysphagia, and vocal changes. The voice sounds as if the child is attempting to speak without moving the tongue, while expanding the oropharyngeal airway. This is described as a hot potato voice. The lateral neck radiograph is obtained to determine the tissue thickness around the abscess. Visualization of the back of the pharynx may reveal a displaced retropharynx, and surgical drainage is the preferred treatment, along with administration of appropriate antibiotics based on culture. Paraglottic obstruction, or epiglottitis. Epiglottitis is a true emergency. We're going to talk about the differences between epiglottitis and croup. This is a lateral neck x-ray of a child showing thumb sign. That is one way you can tell the difference between epiglottitis and croup. Croup has steeple sign, which I'll show you a picture of in just a minute. The obstruction for paraglottic obstruction is below the level of the glottis and can completely block the airway. Let's talk a little about epiglottitis. We'll start with the incidence and etiology. Epiglottitis typically affects children between the ages of 6 months and 6 years old. It results from bacterial invasion of the soft tissues of the larynx, especially those surrounding the epiglottis. 75%, despite vaccinations and reduced incidence of influenza, 75% of epiglottitis episodes are a result of influenza, principally the group type B. There are some non-infectious causes of epiglottitis in children, which include thermal epiglottitis from aspiration of hot liquid, traumatic epiglottitis from repeated intubation attempts, or blind finger sweeps to remove a foreign body. Signs and symptoms include high fever, severe sore throat, inability to speak with drooling, cough, progressing rapidly over a few hours to stridor, muffled voice or hot potato voice without hoarseness, air hunger, and cyanosis. Typically, the child assumes a characteristic tripod position of sitting upright with the chin thrust forward and the neck hyperextended in a sniffing position. Diagnosis of epiglottitis must be assumed based on the clinical presentation. Because manipulation or agitation of the child can trigger complete upper airway blockage, and unnecessary diagnostic procedures should be avoided. No blood gases or chest x-rays. Every attempt is made to maintain a non-threatening atmosphere and keep the child calm until a controlled intubation in OR can be achieved. This should be done under general anesthesia with a pediatrician or a pediatric anesthesiologist. Attempts to directly visualize the epiglottis, draw blood, or insert IVs or lay the child flat should be avoided. Treatment includes establishment of a stable artificial airway first. That is the #1 priority. Placement of an ET tube under general anesthesia is the safest way to provide a secure and temporary artificial airway because of the swelling of the upper airway. Dramatic improvement in respiratory distress is expected after intubation. Once the ET tube is inserted, it must remain in place for 12 to 48 hours or until the tissue shrinks in response to therapy. Treatment of infectious epiglottitis is relatively short. A 2-day course of ceftriaxone is as effective as 5 days of other antibiotics. This may be adjusted based on patient response and on results of cultures and sensitivity reports from blood and epiglottis swabs taken after intubation. Lateral neck x-rays can also be obtained after intubation. If a lateral neck is obtained, you may see a thumb sign on the lateral neck. The child should have constant supervision, arm restraints, and use of sedatives to prevent any self-extubation, and mechanical ventilation will be needed for the short time due to heavy sedation. Generally, extubation is usually considered within 24 hours, or if an air leak is obtained at 20 centimeters of water pressure around the ET tube. Let's move on to croup. Croup is the most common cause of airway obstruction in children between the ages of 6 months and 6 years of age. It typically occurs in fall and winter. Parainfluenza virus 1 is the most common cause. It results in a biannual or every other year epidemic in the United States during October through February, usually of odd-numbered years. Other much less common infectious causes include influenza virus, RSV, herpes simplex virus, and mycoplasmic pneumoniae. The viral infection causes a mucosal edema and exudate formation in the glottic and subglottic areas involving the airways from the larynx to the bronchus, hence the name laryngotracheal bronchitis. The edema develops over several days and the resultant airway narrowing becomes severe enough to cause various degrees of airway obstruction. Obstruction is more severe during inspiration because of the deeply negative airway pressure needed to inhale against the edematous airway, or all that swelling. A child with croup presents with gradual symptoms of low-grade fever, general malaise or just not feeling good, a snotty nose, and hoarse voice. The illness progresses to inspiratory stridor and a barky or seal-like cough. Physical examination reveals nasal flaring, nasal congestion, and use of accessory muscles, and even intercostal retractions if the child is small enough or they become agitated. Estimating the severity of the disease can be difficult. If the ill child is in moderate distress, cold air commonly results in the child becoming virtually symptom-free. Inhalation of cold air reduces the swelling and rapidly reduces the respiratory distress. Much of the attempts to quantify croup severity have centered around the presence of pulsus paradoxus and a croup score. You can see this croup score on table 26.2 in your book on page 506. Diagnosis is a lateral neck showing steeple sign. And treatment includes mostly, here steeple sign is pictured here where the arrow is. Treatment includes supportive care, ensuring temperature control, cool mist to the airway, adequate hydration, and oxygen if the child is desaturating. Nebulized racemic epi may be tried, however, it's an extremely short-term option. Also, administration of oral dexamethasone at 0.6 milligrams per kilogram can also be used. Let's talk about traumatic and postoperative laryngotracheal bronchitis. This airway obstruction or swelling in the airway is that occurs because of endotracheal intubation or injury to the tracheal lining. Cilia in the trachea are easily damaged, especially with aggressive suctioning or endotracheal tubes that are too big. Excessively large ET tubes lead to necrosis of the tracheal mucosa An ETT leak of 20 to 25 centimeters of water is recommended to minimize the presence and pressure problems of an ET tube against the surface of the trachea near the cricoid ring. The value of this leak has been called into question in studies in which the presence of an ET tube leak was found to be less predictive of post-extubation LBT than the duration of the intubation. So shorter intubations make a difference and lead to less postoperative trauma. Longer intubations for small children lead to more problems with the laryngeal-tracheal bronchitis. Lower airway disorders. Bacterial tracheitis is a medical emergency that can result in complete airway obstruction and death. Patients typically have upper airway infection or croup-like symptoms for several days before presenting with a severe airway obstruction. And although the slow progression of this disease resembles croup, the fever, toxic appearance, and elevated white blood cell count with an increased percentage of premature white blood cells or bands all suggest the likelihood of a bacterial infection. Neck and chest radiographs will reveal a narrowing of the subglottic airway with irregular mucosal surface without evidence of epiglottic swelling, so no thumb sign. Bacteria, you'll see the arrows here, you can see the subglottic swelling. Bacterial tracheitis responds poorly to racemic epi and typically requires placement of an artificial airway to manage the copious secretions. Treatment includes antibiotics to cover S. aureus, H. influenza, and S. pneumoniae. The disease resolves more slowly than epiglottitis and requires nearly a week before extubation should be attempted. Let's talk about tracheomalacia. Tracheomalacia is a condition of dynamic tracheal collapse, often caused by abnormal shape and flexibility in the tracheal cartilage rings. Although many times we don't know why this happens, there may be identifiable causes that lead to tracheal wall softening or damage. Common injuries include neonatal ventilation with high pressures, chronic trauma to the trachea from abnormally positioned ET tubes or aggressive endotracheal suctioning, and external compression to the structures. In most cases, tracheomalacia, the infant or child presents with chronic wheezing that becomes more and more severe with vigorous breathing. Fortunately, the abnormality tends to improve with time as the child's airway grows. Congenital tracheal or bronchial stenosis. Like tracheomalacia, congenital tracheal or bronchial stenosis may involve extensive or short lengths of the airway, so a lot or a little may be involved. Severity of symptoms depends on the degree and length of the stenosis or narrowing. A common cause of stenosis in the newborn is malformation of the vascular rings. This happens in infants with congenital malformation of the great vessels of the heart, usually in a double aortic arch. With this malformation, the aorta wraps around the esophagus and the trachea, causing a stricture in the trachea. Infants can present with feeding difficulties and uncontrollable wheezing. Surgical correction of the defect is required to reduce symptoms. However, tracheal stenosis can result from all kinds of different things. Though a funnel-shaped lesion of the pulmonary artery is rare, it can happen, and it can be improved with surgical repair. Intraluminal obstruction. Foreign body aspiration. Foreign body aspiration is a leading cause of accidental death in toddlers. Pictured here is an aspirated coin. The degree of respiratory problems depends on the nature of the material aspirated and the severity of the neurologic deficits depends on the duration of the ventilatory compromise. The sooner that the child gets help, the sooner CPR is instituted and the aspirated foreign body is removed, the better. Mobile infants and toddlers are particularly at high risk because of their tendencies to put things in their mouth and inappropriate toys that can be around for older children that may have loose parts, as well as certain foods like nuts, hot dogs, sausages. They're just the right size to become lodged in a child's airway. The preferred location for small objects is the right middle lobe, which is the most direct and straight connection to the trachea. If the child is neurologically intact, the aspiration commonly occurs if the child is startled or falls while hanging on to and placing such an item in the mouth. Signs and symptoms include a wheezing or recurrent pneumonia when peanuts or popcorn obstruct the airways, absence or partial absence of air movement, and even rapid death from suffocation. These can be seen in things like balloon or hot dog aspiration. If the object is big enough, they can become stuck in the esophagus and can elicit similar symptoms of respiratory distress. The cause of the obstruction and the adequacy of ventilation should be quickly determined. A thorough history of what happened can help, and a complete history is often difficult, however, to obtain. Examiners must determine first and foremost how well the child is breathing, followed by the location of the obstruction. Sudden onset of wheezing, particularly if wheezing never occurred before and is unilateral in nature, should make you suspicious that this may be a foreign body aspiration. Treatment will vary with the severity of the obstruction. If the child is well oxygenated and ventilated, a controlled therapeutic bronchoscopy or laryngoscopy with appropriate anesthesia is preferred. When the foreign body aspiration is suspected and respiratory symptoms are acute, urgent bronchoscopy with removal of the object is necessary. Even if the child appears to be stable, movement of the object can result in sudden clinical deterioration. A child with a complete obstruction may require emergency cryoc to establish an airway. Signs of severe or complete obstruction are an inability to speak or cry, weak or ineffective cough, high-pitched sound or no sound during inhalation, increased difficulty breathing, cyanosis, and the universal choking sign, the thumb and index finger clutching the neck. If intubation and mechanical ventilation are indicated, remembering that these children usually have normal lung function, positive airway pressure may push the foreign body deeper and may create an obstructive ventilatory pattern. Atelectasis. Atelectasis is defined as collapsed lung tissue and is best compared to a wet sponge that fails to re-expand after being compressed. Many things can lead to atelectasis. Inadequate tidal volumes, loss of lung compliance like ARDS, airway obstruction from mucus plugging, increased elastance, all can result in atelectasis. Also, external forces can compress the lung parenchyma with a reduction in lung volumes. These include chest wall disorders like kyphosis and flail chest, or an accumulation of pleural fluid, obesity, or ascites. Signs and symptoms will vary with the cause and severity of the lung volume loss. And although atelectasis is most often found on a chest x-ray, it may be first suspected during a physical exam. You may hear diminished breath sounds, see increased tactile fremitus, tracheal deviation, and elevated diaphragm may also suggest atelectasis. Many patients with atelectasis have no symptoms at all on physical exam. Diagnosis is confirmed with volume loss on a chest x-ray. Treatment is aimed at removing the cause and depends on the individual's clinical course. If it's from a pleural effusion, drain the pleural effusion. If it's from an airway obstruction, remove the airway obstruction, including mucus plugging. Suction the mucus plugs. In an intubated patient, the use of continuous or PEEP, continuous distending pressure, may reverse or prevent further lung collapse, and early mobilization and position changes may help. In postoperative patients, encouraging coughing and deep breathing and PAP techniques and things like incentive spirometries may prevent or often treat atelectasis. Bronchiectasis. Bronchiectasis is defined as the irreversible dilation of the bronchial tree. Typically, the segmental and subsegmental bronchi become irregularly shaped and dilated, and this leads to a loss of that smooth configuration that allows the natural flow of secretions. Also, the cilia are destroyed, and this leads to difficulty mobilizing secretions. The secretions become infected and they pool, and as they pool, they destroy more and more of the bronchi. The lower lobes, particularly the left lower lobe, are most often involved. A small number of patients may have congenital bronchiectasis, in which there's a defect in development of the bronchial cartilage. However, most patients acquire the disease secondary to something else that causes chronic infection. Common causes of bronchiectasis are foreign body aspiration, mediastinal mass, measles, pertussis, pneumonia, Carteniger syndrome, and cystic fibrosis. Bronchiectasis can occur after an infection or patients suffering chronic pulmonary problems like CF. Patients often experience chronic cough with copious amounts of thick, nasty, infected secretions. Some even have hemoptysis or blood streaks. Pulmonary infections are common, and recurrent fever and foul-smelling breath or sputum are also common. Dyspnea on exertion and clubbing of the digits may also be seen with those with chronic problems and chronic lowering of hypoxemia, chronic hypoxemia. The lower lobes, particularly the left lower lobes, again, are the most commonly involved. Diagnosis may be made by clinical history and physical exam. A plain chest x-ray isn't enough. You may need a spiral CT to see the destruction, or even a bronchiography. However, bronchiography is rarely performed today, and spiral CT is more common. Pulmonary functions may be abnormal and may have an obstructive or combined pattern in the most severe cases. Treatment depends on the severity of the disease. Chest physiotherapy, including postural drainage and percussion, is often performed along with keeping the patient hydrated to help mobilize secretions, and use of nebulized hypertonic salines to get them to cough. Antibiotic therapy may also be given either orally or by nebulization, so every other month for preventative measures, nebulized Toby, or even IV if the case is severe. Choice of antibiotic depends on the results. However, Pseudomonas is one of the most common things seen. Let's talk about acute bronchiolitis, often caused by RSV. The term acute bronchiolitis is applied to any condition in infants in which a viral respiratory tract infection results in clinical symptoms of small airway obstruction. Most infants with bronchiolitis, the causative agent is RSV. RSV is highly contagious. It's a virus, and it has the greatest impact on the smallest infants. These infants are those that are younger than 6 months old. The peak incidence for RSV is 2 months to 6 months of age. It is the #1 cause of hospitalization in the United States, and there is considerable variation with the management of RSV. Most cases are mild and don't require any hospital admission. However, December through March, many infections occur of RSV. Postmortem evaluation of infants with severe bronchiolitis reveals obstructive airway from impacted cellular debris, and in vitro studies suggest that an intense inflammatory response has occurred and may contribute to mucosal secretions. Acute bronchiolitis is most often seen in at-risk populations like those born under the age of 34 weeks, those with chronic lung disease, and those with chronic lung conditions like BPD and CF, or chronic congenital heart disease, or immunodeficiency. These are the infants that are at risk of respiratory failure and death from RSV. One new finding that your book doesn't talk about, but that you should hear about and listen for, is that there is a new vaccination that's been recently released for RSV in children. Physical findings in these kids can include cough, respiratory distress, wheezing, and tachypnea. Symptoms of infection usually peak around 48 to 72 hours, and a previously healthy infant can progress from what was thought to be a simple cold to respiratory distress during that time in just a couple of days. When listening to the chest, you'll often hear coarse, sticky, or Velcro-like rawls, which are accompanied by wheezing, intermittent wheezing. A chest X-ray reveals intense lung hyperinflation with flattened diaphragms and an obstructive pattern with occasional film showing evidence of atelectasis or consolidation. Severe life-threatening apnea is a common symptom in very young premature infants, and difficulty feeding is often a result as well. Clinical diagnosis is made from a nasal swab. Nasopharyngeal aspirate or nasal lavage provides diagnosis, and diagnosis is also enhanced by clinical presentation. Clinical history and physical exam should show upper respiratory infection and rhinorrhea, possible lower respiratory infection, history of contact with a sick child or adult, hypoxia, color change, nasal flaring, grunting, head bobbing or wheezing, and signs of dehydration. Treatment is largely supportive, along with careful monitoring. The infection is self-limiting with many patients, and hospitalization is usually not necessary if the symptoms are mild. If the infant has low oxygen saturations or severe symptoms, then hospitalization and support on a high flow, high humidity nasal cannula may be required. Antibiotics are usually not recommended. This is a viral infection, and physician discretion is required. For infants diagnosed with bronchiolitis and otitis media, practitioners should refer to practice guidelines if using antibiotics for a bacterial otitis media. Other medications that may be recommended or used are oral decongestants, over-the-counter cough and cold preparations for older children should not be used due to potential side effects. However, they can be used in children over 2 years old, but shouldn't be used in children under 2 years old. While ribavirin used to be used back in the 1980s, in the days of dinosaurs, it's largely been discontinued. Treatment is generally a trial of nebulized racemic epi or bronchodilators like albuterol and suctioning the upper nasal passages. Primary ciliary dyskinesia. Cilia in patients with this syndrome are not always immobile, but often have uncoordinated or ineffective ciliary movement. The upper and lower respiratory tracts cannot clear secretions and have trouble clearing inhaled particles and other bacteria. The cilia do not beat the way they should. There's often chronic cough, and it's apparent early in the morning and with sleep or exercise. Also present can be mucopurulent secretion, which initially clears with antibiotic therapy. There can be increasing severe airway obstruction and persistent crackles, although wheezing is relatively uncommon. A chest X-ray may reveal lung hyperinflation and changes consistent with bronchiectasis. The upper respiratory tract infections are very, very common, as is nasal congestion and chronic nasal drainage and chronic otitis media, with or without chronic effusions, often occurs, leading to tubes in the ears. Diagnosis can be made rapidly by microscopic evaluation of ciliary movement, and the specimen can be taken from the paranasal sinuses, nose, or tracheal mucosa and looked at under an electron microscope. Treatment focuses on reducing the volume of pooled secretions in the lung. Chest physiotherapy for airway clearance is essential, and a vest may be used as well. Exercise, keeping hydrated, and use of Dornase alpha, as well as Q other month tobramycin is also indicated. It's rarely necessary to have any surgical intervention, but a VATS procedure may be considered. Let's talk about pneumonia in children. Nearly 80% of all pneumonias in children are viral. These occur from RSV, parainfluenza virus type 1, 2, and 3, influenza viruses, and adenoviruses. The first symptoms that are noted usually in RSV, which we've talked about before, are cough, fever, and generally feeling unwell. Retractions, nasal flaring, tachypnea, and wheezes and rhonchi are also common, and a chest X-ray typically shows hyperinflated lungs. Treatment is typically supportive. The parainfluenza viruses are the second most common cause of croup and pneumonia. Type 3 is the most common cause in children younger than 5 years old and occurs year-round with no seasonal peak. Clinical presentation is similar to that with RSV, and chest X-ray will reveal patchy infiltrates or interstitial infiltrates, and diagnosis is confirmed with a rapid antigen testing or viral isolation from a nasal swab. Therapy is supportive with supplemental oxygen and additional hydration as needed. Parainfluenza is not to be confused with influenza virus, which has a very narrow seasonal peak. So let's talk about influenza. Although influenza may cause pneumonia, it occurs predominantly in the very young or very old. and it's usually during the late winter or early spring. Clinical symptoms consist of rapid fever, generally feeling unwell, and the duration is shorter than that of RSV or parainfluenza. Although rare, a rapid pneumonia may result in death within 2 days of onset from influenza virus. Diagnosis and treatment are similar to those of RSV, and flu vaccination is recommended for high-risk children. Adenovirus. Although it occurs year-round, adenovirus pneumonia is often seen in late summer and early fall. It occurs most often in children younger than 2 years old and is easily confused with bacterial illnesses. It mimics their symptoms with a rapid onset, high fever, increased white cell count, and a chest x-ray that looks with an infiltrate. Additional findings may include swollen lymph glands and conjunctivitis with patchy infiltrates. A rapid antigen test or viral isolation from a nasal swab can tell you that it's adenovirus. Close monitoring for bacterial superinfection is also suggested. Let's go on to talk about bacteria. Although the incidence of bacterial pneumonia is much less than that of viral pneumonia, it has a much higher mortality rate. It may occur as a secondary problem to a primary viral pneumonia, as is often seen with pneumonia from influenza virus. Other factors known to increase the risk of bacterial pneumonia include a compromised immune system, recurrent aspiration, malnutrition, daycare attendance, school-age siblings, and exposure to passive cigarette smoke, as well as congenital anomalies of the airway, like a tracheoesophageal fistula. Bacterial agents that cause pneumonia vary considerably through the pediatric age group. In neonates, the most often bacteria that's seen are those that are from the mom, that you get from the mom, like Group B streptococcus or chlamydia. Infants, however, those most commonly seen in infants older than 4 to 6 weeks tend to be S. pneumoniae, H. influenza, and Staph aureus. Less often seen are Bordella pertussis, M. pneumoniae, and C. pneumoniae. Bacterial pneumonia develops when an intrinsic host's defenses are decreased, either by another disease like a virus or when the protective mechanisms are destroyed. Signs and symptoms are similar to those of a viral pneumonia. They are often include headache, fever, generally feeling awful, abdominal pain, a productive cough with sputum, chest pain during inspiration, or pleuritic pain are again common, and physical findings often reveal nasal flaring, use of accessory muscles and retractions, tachypnea, and shallow breathing. When listening, crackles can be heard, increased fremitus, and dullness to percussion. Diagnosis can be made with a chest x-ray. This will show an alveolar consolidation in the area of the pneumonia, or patchy infiltrates. Standard treatment of bacterial pneumonia varies considerably depending on what's causing it. The need for hospitalization is often determined by the severity of the symptoms. Once the cause is identified, antimicrobial therapy is determined and usually given for 7 to 14 days. Atypical pneumonias. Let's start with mycoplasmic pneumonia. Mycoplasmic pneumonia, commonly called walking pneumonia, is seen year-round but peaks in the late summer and early fall. Although it occurs in every age group, it's most often seen in school-aged children and young adults. The incubation period is long, 2 to 3 weeks, and it presents as a typical upper respiratory tract infection. It's hard to spot, with gradually worsening and feeling awful, fever and cough, just like many other respiratory diseases. There can also be headache, nausea, vomiting, and diarrhea. If you listen to the patient's chest, you can hear crackles or sometimes wheezing. Without treatment, the illness generally resolves in 2 to 4 weeks. However, oral erythromycin for 10 to 14 days provides an optimal therapy, and the patient usually becomes afebrile within 48 hours. Azithromycin has also been effective and is widely used as a 5-day therapy course. Another atypical pneumonia is chlamydia pneumoniae. Infected respiratory droplets most likely transmit the chlamydia pneumoniae, and primary infection occurs most often in school-aged children and young adults. However, only a small percentage of portion of patients are clinically symptomatic or have severe illness leading to death. Fever is often present early in the illness but doesn't continue, and wheezing is often heard when you listen to the chest. In fact, this infection has a strong correlation with recent onset asthma. Hosts that have immunodeficiency, malignancy, primary immunodeficiency, or sickle cell disease are at most risk for death. Chlamydia pneumoniae is difficult to isolate even in tissue cultures and requires special handling. It should be treated with tetracycline or erythromycin for 10 to 14 days. Let's talk about ventilator-acquired pneumonia. Ventilator-acquired pneumonia is a pneumonia that happens after being intubated and on a ventilator for 48 hours. Multiple forms of therapy have been attempted to minimize the risk of developing VAP, including hand washing, closed airway suctioning, oral airway care, and elevating the head of the bed. Tuberculosis. TB is the most common infectious cause of death worldwide. Although the frequency has declined since the 1980s and early 1990s, the disease is starting to rear its head again in association with HIV. Patients infected with tuberculosis are often the medically underserved, those that live in poverty, or those with HIV or immunocompromised. Most children do not develop clinical disease unless disease resistance declines as a result of malnutrition, fatigue, or chronic illness. Transmission is airborne and occurs through the inhalation of respiratory droplets in an enclosed space, like living in close quarters with someone with TB. Signs and symptoms include fever, weight loss, and failure to thrive in children. Diagnosis can be made in a variety of ways, with a TB skin test, the Neonatal skin test, or a TB skin test, a positive skin test, chest x-ray, or a blood test. Treatment of TB includes a cocktail of isoniazid, rifampin, pyrazinamide, and etrabutanol. These are given over many months. For those with active disease. The most common combinations are isoniazid and rifampin. Sickle cell disease is an inherited disease. It is an autosomal recessive inherited disorder. It affects the blood and it creates a sickle shape or crescent moon shape to the red blood cells. It is the most common inherited disease in the African American population. Defective hemoglobin S converts from a soluble hemoglobin molecule contained in the red blood cells to a gelatinous or sticky state in the presence of low oxygen, low pH, rapid temperature changes, or hypernatremic dehydration. This gelatinous state causes the red blood cells to become that crescent moon or sickle shape. And it creates a variety of complications that we as respiratory therapists deal with, including acute chest syndrome, cardiomegaly, and left ventricular failure, splenectomy, and renal disease. Pulmonary complications are the primary cause of illness that we see, and death in patients with sickle cell disorder. RBCs are more rigid, and they result in increased viscosity of the blood, which causes them to plug the blood vessels, actually creating roadblocks. Signs and symptoms include acute chest syndrome, which is the leading cause of death and presents as pleuritic or chest pain and dyspnea. The chest radiograph often reveals pulmonary infiltrates located in the lower lobes, as well as atelectasis and pleural effusion. This can affect young children ages 2 to 4 years old, and they can have a fever, cough, and negative physical exam with little or no pain. Treatment includes antibiotics for gram-positive organisms. Erythromycin is used to provide coverage for things like M. pneumoniae and C. pneumoniae, and antibiotics are quickly instituted because these secondary infections can become life-threatening in children with sickle cell disease. Oxygenation is also given to children, and those experience ventilatory failure, mechanical ventilation is used. Successful treatment of acute chest syndrome with high-frequency ventilation, or VV ECMO, has also been reported in those children experiencing life-threatening acute chest syndrome when conventional ventilation has failed. So how do we prevent this? Often chronic transfusion prevention is aimed at antibiotic prophylaxis and transfusion associated and reducing transfusion associated infections. Recurrent aspiration syndrome. Recurrent aspiration syndrome. Neurologically impaired patients, those with abnormal anatomy of their gastrointestinal tract or airways, and patients with reflux are often diagnosed with recurrent aspiration syndrome. The patient aspirates respiratory secretions or stomach contents repeatedly. The patients and their families suffer through multiple hospitalizations for pneumonia and airway hyperreactivity. Children who are treated for frequent asthma exacerbations yet have negative response to allergens can benefit from evaluations for recurrent aspirations, like a swallow study. Diagnosis is based on clinical and radiographic findings. A barium swallow may reveal a tracheal esophageal fistula or other malformations, and bronchoscopy can reveal pathogens normally found in the gastrointestinal tract. Treatment depends on the cause and severity of the disease. Inhaled corticosteroids are indicated to control and reduce airway damage that occurs from chronic inflammation, and prevention of recurrent aspiration is vital to obtain a long-term positive outcome. Prognosis in uncontrolled recurrent aspiration syndrome is guarded because of the chronic re-injury of the respiratory tissue. Respiratory and cardiac insufficiency can develop over time. However, accurate and early diagnosis and prevention of aspiration can reduce the severity of the injury and improve a patient's quality of life. Diffuse interstitial lung disease. There are 4 basic categories of diffuse interstitial lung disease. Disorder of lung development, pulmonary interstitial glycogenesis, neuroendocell hyperplasia of infancy, and genetic disorders of surfactant dysfunction, or surfactant that doesn't work. Diagnosis is based on a systematic approach and on the age of presentation, clinical characteristics, what's found on radiologic testing, and histopathology. Treatment. The cause and severity determine the treatment. Largely, treatment is supported because there is no definitive treatment for many of the rare diffuse interstitial lung diseases. Some interventions like oxygen therapy, mechanical ventilation, or even ECMO are performed when the acute phase is occurring or to get a diagnosis, whereas others like steroids, surfactant, or antibiotics are symptom-based. Thank you for your time and attention today, and I hope this has helped you understand pediatric airway disorders and parenchymal lung diseases. Key points that we went over today. Establishment of an artificial airway in patients with epiglottitis is a first priority and should be performed at the safest place possible, often done in the operating room. Patients with upper airway obstruction tend to have normal lung compliance and function. However, improper ventilation and management can complicate things, such as intubation or tracheotomy. Because crying can cause additional respiratory distress in patients with upper airway disorders, it's vital to keep patients calm and reduce stranger anxiety or irritability. Most airway disorders and lung disease can be classified into 4 big categories: obstructive, restrictive, infectious, or vascular. Some patients have a combination of these diseases, but understanding the primary culprit can assist in choosing the most appropriate therapy. Again, thank you for your time and attention today. Have a wonderful day.